Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Okay, let's set the scene. Imagine you're just moments away from a really significant medical procedure. You're there, maybe in that pre-op room, and well, both you and your doctor are kind of facing a lot of unknowns, aren't you? It's this incredibly crucial moment, steeped in careful calculation and a deeply personal decision. So today, our deep dive is all about pulling back the curtain on surgical risk prediction and patient management. Our mission really is to unpack how medical professionals assess, quantify, and ultimately work to minimize the risks tied to surgery. And maybe most importantly, what that truly means for you, the patient, as you navigate these kinds of decisions.
Yeah, it's an area where the precision required is just immense.
It really is.
All of our insights today, they come from a pretty comprehensive look into excerpts from surgical risk prediction and patient management. It's a piece that truly dives into how medical science really tries, to make every surgical journey as safe and predictable as it possibly can be.
Absolutely. And when we talk about the cornerstone of patient care and surgery, it really boils down to one thing, doesn't it? Understanding risk. The material we looked at really emphasizes that the key to effective patient management isn't just about general safety, like a checklist. It's about identifying and accurately quantifying risk to make truly smart, informed decisions for each unique person.
Right. And what's fascinating here is how these realistic risk estimates, they aren't just numbers on a page. They are actually the fundamental basis for patients truly understanding and agreeing to their treatment plan. Informed consent, essentially. And for that shared decision-making process between the patient and the surgeon, it's all about transparency. If the risks of a particular procedure are judged to be too high or maybe just unacceptable to the patient, well, it's not uncommon for them to jointly decide on something less extensive or maybe even a non-surgical option altogether.
That really clarifies the ethical side of it, doesn't it? So risk assessment isn't just, a good idea, it's foundational. But does this go beyond just broad principles? Are there very specific, actionable guidelines in place?
Oh, absolutely, yes. Take the Royal College of Surgeons in England, for instance. They have some really clear recommendations. If a patient has a predicted mortality risk greater than 5%, that acts like a trigger. It ensures a highly experienced senior specialist doctor, a consultant, is actively involved at every single stage of their management, from the pre-op planning right through to post-op recovery. It's about maximizing every possible safety net.
Okay, that's a high bar, and for good reason, clearly. My mind immediately goes to, what about during and after the surgery itself for these high-risk patients?
Well, the guidelines continue right there. For those patients with a predicted mortality risk over 10%, the surgical procedures themselves should ideally be conducted under the direct supervision of a consultant surgeon or anesthetist, unless, of course, the consultants are completely satisfied with the seniority and the competence of the staff who are managing those patients. And yes, you're right, it extends to post-op too. Patients with over a 10% mortality risk should also be managed in a critical care facility afterwards. It's really about ensuring comprehensive, uninterrupted, high-level care.
So why is identifying these high-risk patients so crucial? It sounds like it's not just about the individual outcome, though that's obviously huge.
That's a really important question. Why focus so much on identifying this group? Well, it's not just about improving individual patient outcomes, which is, of course, paramount, but it's also about the effective allocation of vital resources within the healthcare system. Things like critical care beds, specialist time. Knowing who needs that higher level of care ensures those resources are available and, importantly, utilized where they can have the most impact.
Okay, so we've talked about why predicting risk is absolutely paramount and the strict guidelines that can come with it. But how do doctors actually go from those broad principles to, well, putting a number on risk? What precise tools are in their toolkit?
Right, the how. So the medical community has developed numerous scoring systems over the years to try and identify these high-risk patients. It's been a real quest for precision. One of the most widely used systems, even with its imperfections, is the American Society of Anesthesiologists system, the ASA system. Now, it's broadly used, and it does have a quantitative association with predicted postoperative mortality. There's a link there. But, and this is important, it wasn't originally designed specifically as a risk prediction score for surgery. It's more of a general health status classification.
Yeah, and here's where it gets really interesting about the ASA system, isn't it? Because it wasn't initially designed as that precise prediction tool, it has some limitations, definitely. For example, it doesn't explicitly factor in the patient's age or the specific type, the nature of the surgery they're having. Plus, that term systemic disease used in the ASA grading, well, it can introduce a degree of subjectivity, can't it? Like, imagine if a doctor has to categorize systemic disease without really clear examples. One might call mild asthma systemic, another might not. And that subjectivity, that fuzziness, can make it harder to compare patient risks consistently across different settings. Though our source does note that some examples were added back in 2015, trying to reduce some of that ambiguity.
Exactly. Then you have other systems, like PSM. That's the Physiologic and Operative Severity Score for the enumeration of mortality and morbidity. Quite a mouthful. And its variations, like PPOSM and CR-POSM. Now, these scores are specifically designed to predict all-cause mortality and also non-cardiac complications, but specifically in post-operative critical care patients. So they give doctors a more granular look at the overall physiological stress the patient is under.
Okay, so those sound pretty broad, covering overall outcomes. But what about more targeted tools, focusing on specific risks?
That's an excellent point, because specificity really matters in this field. While ASA gives us that general health picture, Lee's Revised Cardiac Risk Index, or RCRI, it zeroes in on one critical area,
Yeah.
your heart. This index uses objective, weighted scores, things related to the surgery itself and also the patient's pre-existing conditions, their comorbidities. And it uses these to specifically stratify cardiac risk. It's a bit like a specialized stress test just for the surgery. But what's fascinating here and really important is that while the RCRI is excellent for predicting cardiac complications, it is explicitly not designed to predict overall mortality.
I see.
So this really highlights how specialized and nuanced these tools can be. You need the right tool for the right question.
Yeah, that raises a great question about how these tools are actually used together. You can imagine a doctor might use several to get a truly comprehensive view, right? And it sounds like one of the most comprehensive tools they have at their disposal is the ACS NSQIP score, the American College of Surgeons National Surgical Quality Improvement Program Surgical Risk Score. That's another long one.
It truly is comprehensive, though. The ACS NSQIP score can estimate the chance of a complication or even death after surgery for over 1,000 different surgical procedures.
1,000? Wow.
Yeah, it's a web-based tool used before the operation, and it calculates risk based on the specific surgical procedure planned and 19 patient-specific preoperative risk factors. Think of it like a really detailed checklist. It looks at everything from your smoking history and diabetes status to kidney function, even body mass index. It's all about painting a truly granular picture of your unique health landscape before you even get to the operating room. It even goes so far as to compare your specific risk with that of an average person having the same procedure.
Okay, that sounds incredibly powerful. So once all these scores and assessments are in, how do surgeons then use this information? It sort of leads us to the crucial next step, surgical strategy, doesn't it? Matching the procedure to the patient. It's not just about the score itself, it seems, but about choosing the right operation based on that score and other factors. The research we looked at clearly states that patient risk factors significantly influence the choice between one surgical technique and another. And sometimes procedures that aren't usually considered high risk can become so if the patient isn't suitable.
Precisely. And this is where we see something that's often called the laparoscopic paradox. Laparoscopic surgery, often called keyhole or minimally invasive surgery, has definitely become a preferred technique for patients who are prone to postoperative respiratory complications. Lung issues, that's a great benefit.
Right, smaller incisions, less pain, maybe quicker recovery for breathing. However, and this is where it gets intriguing, because of the way laparoscopy affects cardiac physiology, how it impacts your heart and circulation, the same benefits may not apply to patients who are already at higher risk of cardiac complications. It's a really prime example of how a technique that seems better isn't universally better for every single patient profile.
Exactly. It's about finding the right tool for the right patient, considering their specific vulnerabilities.
Yeah.
And this whole trend pushes the boundaries of minimal access surgery generally. The expanding demand, the new indications for these procedures, they're really testing the limits of what the body can physiologically tolerate during an operation. For example, some procedures like robotic prostatectomy or certain laparoscopic colorectal surgeries, they require what's called a pneumoperitoneum. That's when they inflate the abdomen with carbon dioxide gas to create space for the surgeon to work. And they often combine this with steep Trendelenburg positioning. That means tilting the operating table so the patient's head is much lower than their feet, sometimes for several hours.
Oh.
You can imagine the kind of stress that puts on the body's systems.
That sounds incredibly intense, yeah. What are the specific risks linked to that kind of positioning and procedure, especially for vulnerable patients?
Well, our sources indicate this combination can be associated with adverse cardiovascular complications, things like myocardial ischemia.
Reduced blood flow to the heart muscle.
Exactly. And also increased intracranial pressure, essentially, too much pressure building up inside the skull. And these risks are particularly pronounced in those high-risk groups we identified earlier. But the critical takeaway here is that while these advanced techniques offer many, many benefits, the associated risks can be significantly minimized through incredibly careful attention to patient selection. It's like they're not just looking at a raw score from NSQIP or RCRI, but using it as a diagnostic lens to choose the surgical approach that best matches your individual body, your physiology, and your specific health profile.
So, okay, let's bring this back. What does this all mean for you, the listener? We've really covered the incredible precision and the careful consideration that goes into modern surgical planning. It's clearly not just about the procedure itself, is it? It's about expertly matching the patient to the right procedure, supported by detailed, often multifaceted risk assessment tools. It really is a profound commitment to your safety.
It absolutely is. And it's a testament, really, to how far medical science has come in understanding individual patient profiles. We're moving further and further away from a one-size-fits-all approach towards highly personalized care, especially in surgery.
Definitely. And as we wrap up this deep dive, here's maybe a final thought for you to mull over. How might these evolving risk prediction tools and these highly specialized surgical techniques we've discussed, how might they continue to reshape the very definition of who is considered operable, especially for patients with really complex health profiles, and maybe what new possibilities or even ethical considerations might arise as technology keeps pushing these boundaries even further?
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.